Start. Good afternoon, everyone. I am Divyanshu Singh, roll number 121. Today, I am here with my batch from 121 to 135 to present our anatomy seminar on inguinal hernia and appendicitis. I welcome all the professors and my batchmates present here. So, in today's seminar, we will discuss first the anatomy of inguinal canal, so we can understand where the surgical landmarks. We will discuss about Hasselback strangle. We will learn about the types, the clinical types. We will also take two separate cases of direct and indirect inguinal hernia. We will then look about treatment, and then the case of appendicitis will continue. So I would like to call Siddhi to introduce us about anatomy of inguinal canal.
Hello. Okay. Hello everyone. This is Siddhi Dongre, roll number 121, and today I am going to explain you about inguinal canal. So just imagine a person is lifting a heavy object and suddenly there's a swelling in his groin region. Strange, right? But it's actually very common, and the reason behind this is a very small structure known as inguinal canal, about which today I am going to explain you. So, anatomy of inguinal canal. So what is inguinal canal? It is an oblique passage which is musculoaponeurotic and present just above the middle half of the inguinal ligament, which is 4 cm long, and it is placed downward, forward and medially. Now, extent of inguinal canal. It extends from the deep inguinal ring to the superficial inguinal ring. You can think of it like an entry and exit gate. Deep inguinal ring is an entry gate, which is oval opening in the transversalis fascia, and the superficial inguinal ring is an exit gate, which is triangular opening in the external oblique aponeurosis. Now, moving towards the boundaries of inguinal canal. So think of it like this is an inguinal canal and you are standing inside it. So if you see in front of you, there will be the aponeurosis of external oblique, which is forming the anterior wall. Behind you there is fascia transversalis, which is forming the posterior wall. If you see above, this is an aponeurosis of internal oblique and transverse abdominis, which is forming the roof. And if you see below, there is an inguinal ligament, which is forming the floor of the inguinal canal. So I have mentioned it over here also in this diagram. So structures passing through the inguinal canal, obviously it won't be empty if it's there. In case of males and females, some structures differ. Spermatic cord is present in case of males, and round ligament of uterus is present in case of females, and in both males and females, the ilioinguinal nerve is there. So in case of males, the spermatic cord, it carries vas deferens, testicular arteries and veins and pemphigiform plexus. So yeah, that's it from my side. Now I will call Soham to continue.
Good morning, everyone. Myself Soham Lipani, roll number 127. My topic is mechanisms of maintenance of inguinal canal. So basically there are 5 protective mechanisms: flap valve mechanism, shutter mechanism, slit valve mechanism, ball valve effect and mutual guarding. So flap valve mechanism is created by canals obliquity. Shutter mechanism has active muscle closure in which anterior and posterior muscles just apply pressure and close the inguinal canal in order to prevent hernia. The slit valve mechanism has external oblique action in which the oblique muscles just apply pressure in order to prevent prevent inguinal canal opening and therefore hernia. Cremasteric plugging is when the contents of inguinal canal are slightly pulled in order to close the opening, and the other is ring protection. The obliquity of canal is one of the most important factor because the obliquity because the canal passes obliquely through the abdominal wall, creating a flap valve mechanism. When the pressure is increased, the posterior wall is pressed against the anterior wall, which effectively obliterates the canal space, and the failure in this results directly with the directly to hernia. Kate's shutter mechanism, the internal oblique and transverse abdominis, they have arching fibers from the roof of the canal, and during like the condition in which hernia can occur, the fibers contract and therefore prevent hernia. Superficial ring projections involve slit valve, ball valve, and conjoint tendon. Conjoint tendon leads to direct hernia, and its mechanism is to strengthen the posterior wall to prevent. Thank you so much. I would like to call Sneha for his advice.
Hello everyone, my name is Sneha and I'll be covering an important landmark in the abdominal region that has an immense surgical importance. So this is inguinal triangle or Hasselback's triangle. It is present deep to the posterior wall of the inguinal canal, and it can be seen internally in the lower anterior abdominal wall. It is limited by three boundaries. Medial boundary is formed by the lateral border of the rectus abdominis. Superior lateral or the superior boundary is formed by the inferior epigastric vessels, and the inferior border is formed by the inguinal ligament. As we can see in this diagram, it is the superficial view from the anterior aspect of the anterior abdominal wall. We can see that this Hasselback's triangle is present on the posterior aspect of the posterior wall, and this is the internal view. Here is the opening of the superficial ring of the inguinal canal, and we can say that the direct hernia which happens is mainly in the superficial ring and in this Hasselback's triangle. So the roof is formed mainly by the skin, subcutaneous fat and subcutaneous fat and aponeurosis of the external oblique, and floor is formed by the aponeurosis. Floor is formed medially by the conjoint tendon and fascia transversalis. Okay. How do you do that?
खालच्या एरोनी समोर जाते स्लाइड.
So this triangle is being divided into medial and lateral part by this obliterated umbilical artery, also known as umbilical ligament. This has a surgical importance because, as we have seen, the superior lateral border was formed by inferior epigastric vessels. So if there is a hernia in the lateral region, it can cause a hemorrhage during the surgery. And when it is present medially, it is mainly in the due to protrusion through the superficial ring, because superficial ring of the inguinal canal opens in the medial part. Thank you.
Good afternoon everyone, myself Vaibhav Solanki, roll number 128. My topic is definition of inguinal hernia, direct and indirect inguinal hernia. First of all, we will see what is meant by hernia. The hernia is generally the hernia occurs upon the abdominal area. The hernia means the abnormal protrusion of the abdominal content throughout the abdominal wall. There are some common types of hernias. like inguinal hernia, femoral hernia, umbilical hernia, depending on the where the herniation occur. If herniation occur in the inguinal region, it is called an inguinal hernia. Near the pubic tubercle, it is called femoral hernia. Near the umbilical, it is called umbilical hernia. The hernia is of two types: external hernia and internal hernia. As the name suggests, external hernia means which occur or see externally. The external hernia means the protrusion of the abdominal content outside the abdominal cavity, and the internal hernia means the protrusion of the abdominal contents into a space within the cavity. These spaces are known as the no entry zones. For example, if you put foramen opening into lesser sac or foramen of Winslow. The parts of hernia. Every hernia contains three parts. Contains sac of hernia and coverings. The most constricted part of hernia is known as the neck, and the remaining part is known as body. The content of hernia is mainly the loop of intestine. The sac of hernia is the peritoneum, and the coverings are the wall of the abdomen. The complication of hernia. The complication of hernia can be said as the fate of hernia. The hernia can be irreducible, obstructed, or strangulated. First one, irreducibility. In the beginning, the loop of intestine herniates out and comes back. But if the hernia is untreated and remain as such, the loop goes out but does not come back, leading to the irreducible hernia. Obstructed. The loop of intestine. This is the loop of intestine, which have their own their blood supplies, which get cut or blocked due to the shortening of neck of the hernia, and it get necrosis that leads to the strangulation of hernia. The inguinal hernia. The inguinal hernia means the abnormal protrusion of the abdominal content in the inguinal canal or throughout the abdominal wall is known as inguinal hernia. The inguinal hernia are mainly of two types: direct inguinal hernia or indirect inguinal hernia. These two types are differentiated on the basis of where the hernial sac is protrusion. In indirect hernia, the abdominal content enters through the inguinal canal. In the inguinal canal, and the direct inguinal hernia, the abdominal content enters the inguinal canal through the posterior wall. We can see through this diagram the difference between indirect and direct inguinal hernia. If this is the anterior wall of the abdomen, this is the posterior wall of the abdomen, this is the inguinal ring. This is the deep inguinal ring. This is the superior inguinal ring. If the inguinal hernia enters through the deep inguinal ring, it is known as indirect inguinal hernia. If it is moved directly through the posterior wall, it is known as the direct inguinal hernia. Second point, causes. The causes of the direct inguinal hernia are two: congenital causes and acquired causes. The more common are the congenital causes, which occurs due to the persistence of the processus vaginalis. Processus vaginalis is the embryological peritoneal sac enters in the scrotum, and the acquired indirect hernia occur due to the increase in abdominal pressure. Direct inguinal hernia occurs mainly due to the acquired due to the weakness of the muscles. Third point, the entry of hernial sac lies laterally to the inferior epigastric artery. This is the inferior epigastric vessels. If the hernia enters laterally, means directly through the inguinal canal, it is known as indirect inguinal hernia. If the hernia enters through the medial side, it is known as direct inguinal hernia. Direct inguinal hernia on the basis of entry of the hernial sac. Direct inguinal hernia is divided into two types: lateral direct inguinal hernia and the middle inguinal hernia. As discussed before, the Hasselbalch triangle is divided into two parts: lateral and middle. If the hernial sac enters through the lateral side, it is known as lateral direct inguinal hernia. If it is enters through the medial side, it is known as medial direct inguinal hernia. Last fourth point: coverings of the indirect inguinal hernia. As discussed before, the hernia has three parts: contains, sac, and coverings. The coverings of the indirect inguinal hernia are external parotid, extraparotid tissues, internal spermatic fascia, cremastic fascia, external spermatic fascia, and skin. The coverings of the direct inguinal hernia, the lateral direct inguinal hernia are lateral direct inguinal hernia are extraperitoneal tissues, fascia transversalis, cremastic fascia, external spermatic fascia, and the skin. And the medial direct inguinal hernia coverings are extraperitoneal tissues, fascia transversalis, conjoint tendons, and extraspermatic fascia and the skin. Thank you.
Good morning, I'm Akash, roll number 124, and I will be continuing with the clinical types of inguinal hernia. First, reducible hernia. In this type of hernia, the swelling appears while standing, and it can be reduced by lying down or by applying pressure. In this, usually there is no pain, but and the blood supply is also intact. Second, irreducible hernia. In this hernia, the swelling does not reduce by lying down or by applying pressure. There might be slight discomfort present, but the blood supply is still intact. Third, obstructed hernia. In this, the lumen of the hernial sac is narrowed, so that's why the content cannot be moved forward or backwards. It is featured by abdominal pain, tenderness, and blood supply is still intact. Fourth, strangulated hernia. It is the most important type of hernia, as in this the blood supply is cut off, and it is featured by pain, severe pain, tenderness, and intestinal obstruction like abdominal distension, vomiting, etc. Fifth, inflamed inguinal hernia. In this, the content of the hernial sac are inflamed, example appendicitis, appendix, and the features in this are redness, tenderness, and severe pain. Sixth, sliding inguinal hernia. In this, the retroperitoneal organs like sigmoid colon and cecum forms the part of the inguinal hernial sac, and it is of surgical importance because of the risk of internal organ injuries. Seventh, recurrent inguinal hernia. This hernia reappears after repair surgery. It is either due to weak repair or by raised intra-abdominal pressure. Thank you.
Good morning, one and all. Myself, Ruturaj Trisat, roll number 125, and I will. Today's seminar topic is special test for inguinal hernia diagnosis. First test, expacial cuff test. In this test, we have to put a finger on the inguinal ring and tell the patient to cuff forcefully. If we feel the pulse, then it is an hallmark sign for inguinal hernia. The impulse reflex increase the intra-abdominal pressure. The quality of impulse helps to determine whether it is a hernia or lymph node or it is a lump. Second test is deep ring occlusion test. It is also known as Siemens test. In this test, with the help of finger, we occlude the deep inguinal ring and then ask the patient to cough. If the impulse is felt, it is an indirect hernia, or the impulse is not felt, it is a direct hernia. Third test is invagination test. In this test, with the help of finger, we invaginate the scrotal skin upward into the abdomen in the inguinal canal and then into the spermatic cord, and then ask the patient to cough. If you feel a bulge on the fingertip, then it is an indirect hernia, as the sac descends down through the internal ring towards the scrotum. And if you do not feel an impulse on the fingertip, or you feel an impulse on the pulp, then it may be indicative of direct hernia. Fourth test is reducibility test. In this test, we manually attempt to reposition the palpable hernial bulge back through the inguinal canal into the abdominal cavity. If it is a reducible hernia, then the bulge will be back into the abdomen. And if it is a irreducible hernia, then the bulge will not be pushed. Fifth test is ring invagination test plus standing lying test. This test combines the invagination test along with the positional changes to confirm the hernial behavior, in which we perform first the invagination test, then ask the patient to stand and then cough. While standing and coughing, the hernial bulge will reappear and it may be prominent. And when the patient is told to lie down, the hernia will be reduced. Sixth test is three-finger test, in which we place our three fingers along the inguinal canal. Three finger we use are index, middle, and ring. Then by this we can distinguish the hernia type on the basis of the direction of cough impulse. If the direction of cough impulse is from outward and upward, then it is indicative of indirect hernia. If the direction is direct from forward, then it is an indicator of direct hernia. Thank you.
So my name is Divyanshu Singh, roll number 122. So I am here to present today case study and differential diagnosis. So our first case is of a 25-year-old patient. He was presented to the surgical department with the chief complaints were swelling in the groin region for around 4 months and discomfort on exertion. The history of present illness included the swelling was gradually increasing in size and extended toward the scrotum. It became more prominent on standing and coughing, and there was no history of sudden increase in size or severe pain. Also, there was no history of trauma, abdominal distension, severe pain, vomiting, or irreducibility. On local examination of the inguinal region, we performed the deep ring occlusion test. The swelling did not reappear, suggesting an indirect hernia. So this is the probable diagnosis is of indirect inguinal hernia. The next case is of a 55-year-old male patient, manual laborer. So this itself helps us to identify that it may be of direct inguinal hernia. The chief complaint were swelling in the right groin for 6 months and discomfort on exertion. The history of present illness included small swelling in the right groin region, and it became prominent on standing, coughing, and straining. Reduces on lying down. Again, there were no history of trauma, abdominal distension, irreducibility, and severe pain. On local examination, the deep ring occlusion test, the swelling reappeared after pushing back the hernia. So it indicates of direct inguinal hernia. So to basically differentiate between direct and indirect diagnosis, the main points are the site of protrusion of direct inguinal hernia is through posterior wall of inguinal canal, mainly due to the weakness of the abdominal muscle, and it also lies medial to the inferior epigastric vessel and more common in older males. Indirect inguinal hernia follows the path of inguinal canal, and it protrudes through the deep inguinal ring, travels to the superficial inguinal ring, and commonly enters the scrotum. It is usually congenital, hence it is more common in young adults. Yes. So these are the diagram. So next we come to the differential diagnosis. So the most common differential diagnoses are femoral hernia, hydrocele, lipoma of spermatic cord. So first we will talk about femoral hernia. So femoral hernia basically protrudes through the femoral ring into the femoral canal. The swelling lies posterior or inferior to the inguinal ligament. It is more common in females. Also, the swelling occurs near medial to the femoral vein. So, femoral hernia usually compresses the femoral vein. Also, it is irreducible early and it has high risk of strangulation. The next is hydrocele. Hydrocele is one of the most similar to the hernia. Hydrocele literally means a water tumor. In this, there is fluid filled in the tunica vaginalis layer of the testis. It is easily differentiated from inguinal hernia by transillumination, in which the transillumination of the testis is seen in case of hydrocele. Next is lipoma of spermatic cord. Lipoma means the abdominal fat is protruded into the groin region. It does not usually enter the scrotum. It is also the most common type of benign tumor of spermatic cord. It does not change with position and cuff impulse is absent. Next is inguinal lymphadenopathy. It is on palpation, multiple node swelling are seen. The nodal swelling are usually due to local infection or STIs, and cuff impulse and reducibility is absent. Thank you. Now I'd like to call Rishika.
Hello, I'm Rishika Singhania, roll number 123. Now we are finally moving on to treatment of inguinal hernia. Inguinal hernia can ultimately not be cured properly with conventional methods. However, sometimes we need to observe the patient's condition for a period of time before the surgeries. For these cases, the conventional methods are used. These can be used for asymptomatic men since they exhibit extremely low risk of emergencies. They can also be used for pregnant women as the risk of surgery is much higher than the risk of waiting. Furthermore, a 2017 study showed that most of the women completed their duration of pregnancy without major complications from the inguinal hernia. However, this can definitely not be used for symptomatic men since the risk of incarceration increases. Incarceration basically means that the contents of the hernia get trapped and the bowel movement is blocked. This leads to pain and vomiting. They can also not be used for non-pregnant women, as in these the risk of strangulation increases. As said by Weber, strangulation means that blood supply is cut off to a part of the intestine. So what exactly do we do in these methods? First, we can employ watchful waiting, applying ice to reduce the swelling, pain medications, and lifestyle modifications. This includes diet and weight management, avoiding strenuous exercises, and also avoiding strain during bowel movement. All these ensure that the abdominal pressure is not increased. A surgical belt can also be used to hold the herniated area in place. While this has a twofold mechanism, it is unfortunately not curative. So what is the cure? Surgical methods. These include herniatomy, plasty, and raphe. Herniatomy basically means that we cut the sac open, we push the contents back, we tie the sac at the neck, and the sac is removed. Hernioplasty makes use of mesh, while herniorrhaphy makes use of suture to repair the weakness. Herniatomy. The word tracheotomy means removal, that is removal of the inguinal sac. This is mostly used for children because they exhibit indirect congenital hernia due to patent processus vaginalis. That is, there is no posterior wall weakness. So they do not require any further strengthening of the posterior wall. As I'll be presenting a few second video after this, I'll keep the steps brief. First, we make an oblique skin incision. Next, we divide the superficial fascia, and the external oblique aponeurosis can be visualized along with the superficial inguinal ring. Now, we incise the aponeurosis, and the contents can be seen. Next, the spermatic cord is lifted off, and the sac is freed up to the deep inguinal ring. We can confirm the location of the ring by visualization of the extraperitoneal fat. Finally, the sac is transfixed, and the sac is excised. It is also important to note that sometimes the sac may extend up to the scrotum, and in these cases separation is difficult and the distal end of the sac can be left as such. Next, hernioplasty. Hernioplasty basically follows herniatomy with the additional use of strengthening the posterior wall through use of sutures or a mesh. We also make use of a proline mesh to bridge the gap between the inguinal ligament and the conjoint tendon. Hernioplasty has two main approaches, open repair and laparoscopic. A laparoscope is basically a thin, long tube with camera and lights. While open repair provides us with direct visualization, a laparoscope makes use of three ports, as I've shown in the diagram image there. But the relative positions of the ports can vary according to the surgical requirement. The main difference is that in open repair, the mesh is placed over the posterior wall, while in laparoscopic surgeries, the mesh is placed in the preperitoneal space. The open repair can be bassini repair, or the most popular is Lechstein tension-free repair. For laparoscopic, there can be two main methods, that is total extraperitoneal or transabdominal preperitoneal. Laparoscopic surgery is comparatively less time-consuming and ensures faster recovery. Oftentimes, the patient can be discharged on the next day, if not the same day. However, this requires work of an extremely skilled surgeon. All surgeries have their own complications, but inguinal surgeries are relatively advanced since it is the only definitive treatment. Thank you.
Good morning everyone. My name is Prashant Jangam, roll number 130. Today me and my colleagues will be presenting on topic of acute appendicitis. So I will give a brief introduction of on this topic. So at the end of this session, you will be able to understand about anatomy of appendix, peritoneal relations and position, different types of position.
एजेंडा टाइटल गलत है, एजेंडा के बजाय स्पेसिफिक लर्निंग ऑब्जेक्टिव ऐसा लिखना चाहिए, या सेशन गोल्स जैसे सर लेते हैं.
And case presentation, blood supply, nerve supply and lymphatics, appendicitis and clinical signs, and etiology and pathophysiology, complication management and appendectomy. So I would like to call Suhani to explain anatomy of appendix. And I will back for present a case.
A very good morning to everyone. Myself Suhani Lohia, roll number 132. So as we know, before studying any case, it is very important to know about the general anatomy, the relations of the organ that is affected. So in our case of appendicitis, it is very important for us to know the general anatomy, the relations, the peritoneal relations, as well as the position of appendix. So starting with the general anatomy.
Gross anatomy you mean to say.
Yeah. So according to the gross anatomy, appendix is a blind tubular shaped structure. It is of length 2 to 20 centimeters and of diameter 5 mm. As you can see, there are three parts of appendix. This is the base, this is the body, and this is the tip. The next important thing to know about any organ is to know about its location in our body. So as we all know, appendix is present in the right iliac region, and there is one of the most important points related to appendix, that is the McBurney's point. McBurney's point is present on the line joining the appendix and the right anterior superior iliac spine. This point is present such that lateral to this point is 1/3 part and medial to this point is 2/3 part. It is just below this point that the base of the appendix is present. Next, coming to the peritoneal relations. So according to the peritoneal relations, appendix is an intraperitoneal organ and it is related to the mesoappendix. Mesoappendix, as you can see in the image, mesoappendix connects the appendix to the ileum. Next is the positions of appendix. So in total there are 7 positions of the appendix in our body. First is the retrocecal, which is the most common in human beings. According to that, appendix is present behind the retrocolic, in which the appendix is present behind the colon. Next is the paracolic, in which the appendix is present just besides the colon. Next is the mid-inguinal, in which the appendix points towards the inguinal ligament. Next is the pelvic position, in which the appendix is pointing towards the pelvis. Next is the promontoric region, in which the appendix is pointing towards the sacral promontory. And the last two are the pre-ileal and the post-ileal, according to which the appendix is present in front and behind the ileum respectively. It can also be, the positions of appendix can also be denoted by the clock system. So according to the clock system, if we consider this to be a clock, this is 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock. So this is retrocolic, which is 12 o'clock. This is paracolic, which is 11 o'clock. This is mid-inguinal, which is 6 o'clock. This is pelvic, which is 4 o'clock. This is promontoric, which is 3 o'clock. And the last two are the pre-ileal and the post-ileal, which are 2 o'clock. So this is from my side. Now I would like to call upon Prashant for the case presentation.
So let's discuss a case. A 22 years old male person coming to surgical outpatient department with complaints of abdomen pain and vomiting, fever for 1 day. So history of present illness, there are pain at umbilical region and which was vague and dull and poorly localized. So the pain will shift towards the right iliac fossa. When it's continue, it will get more severe in nature. So the pain aggravated by movement and coughing. When person is lying still, so pain will get relieved. So it associate with nausea 2 to 3 times 2-3 episodes of non-bilious vomiting and low grade fever. So there are no history of burning of micturition, no history of increased frequency of urination, hematuria, diarrhea, constipations, and no history of any similar episode in the past. So on local examination of the abdomen showed decreased movement at right side during respiration. On palpation, the tenderness observed at McBurney's point, as the McBurney's point I already explained by Suhani. So along with guarding this right iliac fossa and rebound tenderness is present. Rousing sign and sauce test is positive. So this the sauce test and rousing sign further explain in further will explain in further slides. On percussion, tenderness is noted in the right iliac fossa. On auscultation, vowel sound are slightly reduced. So, thank you. I would like to call Prathamesh to explain blood supply, nerve supply, and lymphatics. Thank you.
वास्कुलर इनर्वेशन होता है क्या? वास्कुलर एंड न्यूरल इनर्वेशन क्या होता है? वास्कुलर सप्लाई होता है.
Good morning, myself Suryansh Prathamesh, roll number 135, presenting seminar topic on the vascular supply and neural innervation of appendix, lymphatics, appendicitis, and clinical sign used in diagnosis of appendix. First of all, we are seeing arterial supply. The main arterial supply of appendix is appendicular artery, which is a branch of ileocholic artery. As shown in the diagram, we can see that superior mesenteric artery gives a branch ileocholic artery, which enters in right iliac fossa, gives cholic branches from which appendicular artery originate and enters mesoappendix and supplies the base of appendix. The important point to note here that the appendicular artery is an example of end artery, as there is no collateral circulation for it, due to which in appendicitis it can be thrombosed and causes vascular necrosis and maybe rupture of appendix. Next is venous supply. That blood from appendix is drained by appendicular vein, ileocholic vein, and superior mesenteric vein, finally to portal vein.
Is it connected to internet?
ऑफलाइन बता रहा है. ये क्या ऑनलाइन था क्या इमेजेस?
We have to discuss both sympathetic supply and parasympathetic supply. The sympathetic supply of appendix is T9 and T10 segment of spinal cord through the colic plexus, and the parasympathetic supply is from vagus. The important point to note here that in appendicitis, pain is first felt in the region around umbilicus, and with increased inflammation, it shifted to right iliac fossa due to the T10 segment of spinal cord supply both the region around umbilicus as well as appendix. It is called as referred vein. Next is a lymphatic drainage. Appendix is also called as abdominal tonsil because the submucosa of appendix contains many lymphatic masses, and the lymphatic drainage of appendix is a fairly organized pathway. We can see in the diagram that from the appendix, the lymph is drained in the mesoappendic lymph node, then the ileocholic lymph nodes, and finally to superior mesenteric lymph nodes. Now we are discussing about appendicitis and the clinical sign used in the diagnosis of appendix. What is appendicitis? Appendicitis is a sudden inflammation of appendix which require immediate medical attention. It has symptoms like low-grade fever, abdominal swelling, abdominal swelling.
एब्डोमिनल स्वेलिंग क्यों? बोलो आगे बोलते जाओ.
Then clinical sign used in diagnosis of appendicitis. First is McBurney's point. McBurney's point corresponds to base of appendix, and it is the site of maximum tenderness. The points lie at the junction of medial 2/3 and lateral 1/3 line joining umbilicus and the right anterior superior iliac spine. Then Rousing sign. Rousing sign is that when we apply pressure in left iliac fossa, then pain is appreciated in right iliac fossa. That due to pressure, the coils of ilium shifted slightly to right and apply pressure on the appendix, due to which pain is appreciated. Third is Voss sign. When appendix is retrocecal, the extension of hip joint stretches the Voss major muscle and disturbs appendix, which cause inflammation. Fourth is obturator sign, that in pelvic appendicitis, the pain may be felt in thigh when the thigh is flexed and medially rotated. It stretches obturator internus muscle, which can apply pressure on the appendix and cause inflammation, and pain is appreciated. Thank you. This is from my side, and I would like to call Srideva for further presentation.
Good morning everyone, my name is Srideva Thati and today I will be discussing etiology and pathophysiology of appendicitis. Starting with etiology, the luminal obstruction is the most common cause of appendicitis. Various factors cause it. First, we have appendicolits. They are hard stone-like fecal concretions that can lodge in the lumen. Second, we have appendiceal tumors like appendiceal adenocarcinoma, mucocele, and adenoid tumor. Then we have intestinal parasites like roundworm and pinworm infections. Then we have hypertrophy of lymphatic tissues, and foreign bodies like undigested seeds can lodge in the lumen and cause the obstruction. Strictures, they have fibrotic narrowing caused due to inflammation or infection. And in the pediatric population, the most common cause is hypertrophy lymphatic tissue. Whatever the etiology is, there is obstruction of the lumen. So the wall of the appendix, they have cells that are constantly secreting the mucus, and that is to prevent the pathogens from entering the blood circulation and to keep the tissue moist. So in case of obstruction, the intraluminal pressure, it increases, and the swelling of the appendix then presses on the afferent visceral nerve fibers that can cause the abdominal pain. Then we have the gut flora that are usually kept in check like E. coli, Bacteroides and Enterococcus. But in this case, they will multiply and then they will attack the immune system and cause an increase in WBC count. And as the pressure increases further, we have venous congestion, lymphatic stasis, and reduced arterial perfusion, because a decrease in oxygen supply to the cells. So now the cells are compromised, so the mucus that it secretes is compromised. So that causes ischemia and necrosis. And then the colony of the bacteria that is present in the lumen, they are allowed to invade the appendix wall, because of which there is inflammation. Now, if this inflamed appendix is left untreated for a very long time, then we could have ulceration that could then result in a ruptured appendix, and that would be followed by complications like peritonitis, abscess, and gangrene. So the patients would either present with a complicated appendicitis or an uncomplicated appendicitis. In the uncomplicated one, it's just the inflamed appendix without the perforation, the abscess, and gangrene. But in the complicated appendicitis, it will be discussed further. We'll have all of this like peritonitis, rupture, and then the inflammation that is spreading to the whole cavity. Thank you. Now I'd like to call Suryansh to continue.
A very beautiful afternoon to everyone present here. I am Suryansh Rajwade, roll number 134, presenting with differential diagnosis, differential diagnostics, and complications of more or less related to appendix. So, acute cholecystitis. So, typically occurs in fatty fertile female of 40, and there is a severe pain in the right hypochondrium radiating to the right shoulder along with vomiting and nausea. There is tenderness in the gallbladder, and there are possible Murphy signs as well. The diagnosis with Charcot's triad, that is pain, jaundice, and rigor. The best tool for the main diagnostic tool is ultrasound. Right? Acute pancreatitis. They're common in patients over 30, slightly more prevalent in male than in the females. There is severe agonizing pain in the epigastrium radiating to the back or left loin with elevated serum amylase, and can be diagnosed with CT scan. Peritonitis. So peritonitis, there is a
there is there is ruptured appendix, inflamed appendix which get ruptured, and due to which the bacteria spreads all through the abdominal cavity, causing intense pain, fever, nausea, and rapid heartbeat. Can be treated with intravenous antibiotics and can be treated with appendectomy. Periappendiceal abscess. So periappendiceal abscess is the complication of acute appendicitis with the pus gets collected all around the abdominal cavity, all around the appendix, which causes the lower right abdominal pain, fever, and nausea. Can be treated with this treatment is usually involves the conservative method using the intravenous antibiotics. Lastly, gangrene. Gangrene is a severe advanced stage of appendicitis, which causes the cell tissue death, that is necrosis of appendix due to loss of blood supply. Symptoms are lower pain, fever, nausea, chills, and intense tenderness in the appendix region, and can be diagnosed with CT scan. Treatment is appendectomy. If goes untreated, it can lead to perforation, sepsis, and septic shock. Thank you. I would like to call Sumit Aswar for further elaboration.
Good afternoon, everyone. Myself Sumit Aswar, roll number 133. I am here to present a seminar on topic appendicectomy. Appendicectomy, it is a surgical removal of vermiform appendix, and it is most commonly performed for acute appendicitis. It is of two types, laparoscopic and open. Laparoscopic appendicectomy, there are three ports. There are three ports, umbilical and camera port, and suprapubic port, and left lower quadrant port. Umbilical port, through which the camera port is
shivering.
Umbilical port through which camera is inserted, suprapubic port through which appendix is retracted, and then surgical steps of laparoscopic appendicectomy. First, creation of pneumoperitoneum, that is intestinal introduction of gas like CO2. Then second is identification of appendix. Third, dissection of mesoappendix. Fourth, ligation of appendicular artery. Then bias ligation, which is of two types, endoloop and stapler. Sixth, removal of appendix. Then open appendicectomy. There are two incisions, McBurney's incision and Lance's incision. McBurney's incision is public incision in the right iliac fossa, and Lance's incision is transverse surgical incision in the right iliac fossa, and it is cosmetically better. Surgical steps of open appendicectomy: incision at McBurney's point, then layer by layer dissection of anterior abdominal walls, then opening of peritoneum, then identification of cecum by tracing tinea coli. It is delivering appendix. 6, ligation of mesoappendix, then ligation of appendix base. 8 is removal of appendix and then closure of layers. Thank you. I would like to call over to
Good afternoon. Myself Kasim Take, roll number is 129. Today I am here for the summary. So first of all, we are going to see inguinal hernia. Inguinal hernia is the protrusion of abdominal contents, such as intestine or omentum through the inguinal canal. Due to weakness in the abdominal wall, it commonly presents as a groin swelling that becomes more prominent on standing, cupping, or straining, and reduces on lying down. It may be direct through Hazelback's triangle or indirect through the deep inguinal ring. Clinical types include irreducible, obstructed, strangulated, inflamed, sliding, and recurrent hernia. Diagnosis is mainly clinical, using tests like expansile cuff impulse, deep ring occlusion test, and invagination test. Treatment may be conservative in selected cases, but definitive management is surgical by herniatomy, herniorrhaphy, or hernioplasty. And second one is acute appendicitis. Acute appendicitis is sudden inflammation of vermiform appendix, usually caused by obstruction of the appendiceal lumen by appendicolis, lymphoid hyperplasia, parasites, or tumors. Pain typically starts around the umbilicus and later shifts to the right iliac fossa at McBurney's point. Associated with nausea, vomiting, fever, and tenderness. Important clinical signs include McBurney's tenderness, Rosin signs, SOS sign, and obstructor sign. Complications include perforation, gangrene, periappendiceal abscess, and peritonitis. Management is mainly surgical by appendicectomy, which can be performed by open or laparoscopic method. So yeah, thank you. I would like to mention Dr. Ditya Roy ma'am and Divyanshu, बहुत मदद किया इन्होंने. Thank you.
Sir, concluding remarks. Sir. You, sir. You, sir. Good effort.
Part was that you finished in 58 minutes.
Yes. ये लास्ट का स्लाइड सबसे अच्छा है.